Let's go. Oh, we have a nice audience on Zoom. Hi, everybody. If you see me, I'm actually looking at you, but if you see the side of me, I'm looking at everyone out here. So happy you're here for today's presentation. Just a couple quick announcements. There's a couple pages that you have. One is all of our upcoming events. December is actually pretty busy, especially next week. As you know, our pillars of the RVNA Health Parkinson Center is to always provide 3 things a month. 1 is support, 2 is education, and 3 is something social. So today is our educational presentation. We have a Zoom support group and an in-person support group. First time ever, because the in-person has been so popular, yet it's really tough to toggle with the technology. So it's Zoom only. How nice is that? It's the second Monday of the month at 11. So next Monday is the first one. And then come back in person for a holiday sing-along. We all know everybody's probably been through therapy and heard big and loud. We need to use our loud voices. What a great opportunity to get it out there and sing together. If you don't even like the holiday songs, consider it exercise for your voice. But the 2 music therapists have already made a list of songs, and I think they play guitar. They have another patient with Parkinson's who plays keyboard. There was someone else that wanted. I think it's going to be a full band here. So we really need an audience, because it would look silly if there were more people up front than actually coming. So please come to that. What else? Then our in-person Zoom group at the end of the month. And then we have some really exciting stuff going on in January. So if you registered, but this is your first event, make sure you also sign up for the Parkinson Center emails. And you can do that on the website, rvnahealth.org/PD Center. And in the middle of the page, it says, join here, start here, whatever that big button that calls you to hit it, put your info in, and that way you'll get all of our email communications. The other thing is, I don't have Parkinson's. I'm doing this because we want to help you guys. So tell me more about how I can help you. This is a survey about all the ideas that we thought would be cool to help you. But could you tell me if you would come to this holiday sing-along, or if you think that is silly, or if you have a better idea? I am all ears. So tell me how interested you are in some of our programs. Another thing I hear is, oh, I'm driving so far. I really wish things were consolidated. Sure, I'll put a support group back to back with a social event or education so that you have less driving. Other people don't want to sit, but you guys are here. So please answer. You guys on Zoom will get this survey in an email tomorrow. And I would love if you could also fill it out and get it back to us, because we want to make sure we cater to your needs there at home. And with that, I'd like to introduce Dr. Connors to come and speak about deep brain stimulation. And we have Joe from Abbott, who works with the surgeons and programs. And then we have Randy here, who is a patient, and he will talk about it. So I think this is casual, just talk, questions, anything. You on Zoom, if you have a question, I think just unmute and ask away. All right. Can you get through there?
Yeah.
It's a little tight.
Okay. All right. Okay. Good afternoon, everyone. So my name is Chris Connor. I am the newest neurosurgeon at the University of Connecticut, and I was hired there to do a set of operations and a set of different kinds of neurosurgery, which I'm going to talk to you guys about today. So my specific area of practice in medicine is called functional neurosurgery. And to give you guys an idea of what that is, there's a lot of things that we do in neurosurgery, which is the art of operating on the brain and the spine, that make a lot of sense. Okay, I always explain spine surgery is easy to understand, tumor surgery is easy to understand, aneurysm surgery is easy to understand. And all the neurosurgeons took all those things and they made them specific areas of neurosurgery. And this left a bunch of random stuff. Okay, it left epilepsy surgery. Okay, it left surgery for different kind of pain conditions. And it left surgery for movement disorders. Okay, and they lumped all that stuff together, even though it's not really related at all. And they called it functional neurosurgery. They did a couple other things. Mostly they made the reimbursement for it really terrible, which is a problem for me, not a problem for my patients. But that's what functional neurosurgery is. It's really related to restoring function of the brain and the nerves. Okay. And so the thing about functional neurosurgery that I'm really passionate about, that I've spent a lot of time doing training in, is in an area of it specifically called deep brain stimulation, which many of you are probably familiar with. It's a part of neurosurgery which is dedicated towards treating a bunch of different diseases, but the most widely known and appreciated is Parkinson's disease. And so I'm sure many of you in the room have heard a little bit about this and about what we do and what the goal is. And we're going to hear a little about that from a patient perspective in a little bit, but I'm going to tell you what it is from the neurosurgeon's perspective. So what deep brain stimulation is the easiest way to think about it, and the way that I explain it to patients is it's basically like we're doing like a cardiac defibrillator or like a pacemaker, but for the brain. Okay. Parkinson's disease is a degenerative disease. It's a disease which causes some parts of the brain not to communicate very well with one another anymore. And when that happens, when that happens, the brain's ability to generate signals to control your body are impeded. Okay. And that can result in a whole bunch of different symptoms, which we're all familiar with. It results in movements being slower, which is actually the cardinal symptom of Parkinson's disease, bradykinesia. Once heard of bradykinesia. It results in tremors sometimes in some patients, and it can result in rigidity. And these are just three of the motor symptoms among a whole constellation of things that goes on when someone gets Parkinson's disease. So the goal of deep brain stimulation and a functional neurosurgery is to kind of start to reverse that. How do we do that? Well, again, it's like we're implanting a pacemaker, but for the brain. And so there's an implant, and Joe's going to actually pass one of these out. I've seen him playing around with it right now. But when he's up here talking to us, he's going to pass around. There's a battery that we implant, and then there's a couple of wires that we implant in the brain. We run current through these wires, and that actually can help some of the rhythmicity or some of the rhythms in the brain to correct themselves. And that can treat a lot of the symptoms of Parkinson's disease. Okay. This is the kind of thing that's on all the time, and it's a permanent implant that we do. We've been doing this for a long time. So the treatment of Parkinson's disease actually initially started with what are called lesions of the brain. So initially, the way that we actually came to the realization that we can do this was that people would do things where they would actually remove parts of the brain, or they would cause small strokes in the brain. And we found out that you can do that on accident, actually. We found out that in a series of patients that when we did that to a very specific part of the brain, it would improve tremor. And then this grew into, well, we don't want to necessarily remove parts of the brain or damage the brain. Instead, what we want to do is we want to implant something that will improve function. Okay. So right there, that's the battery that we implant. Yeah, it's not small. But that battery has to, the perspective I have on it is the battery has to last 5 years. So these batteries last a long time. There are rechargeable ones, but they have their own set of different things.
And now we're coming out in mid-January, end of January. That's the size of it.
Oh, this is a spinal cord stimulator,
Yeah,
but it's the same
one.
it's the same footprint. Okay.
Yep.
Sometimes the rechargeable ones are a little bit smaller.
So while you're in there installing this, can you cut off the wire that makes you hear your wife when she's?
We get asked all kinds of questions. Yeah, we get asked that. You know what your wife would ask us? Your wife would ask us, "Hey, can you cut the part that makes him crazy, or that makes him ornery, or that doesn't want to make him do the dishes?" We can't fix any of that stuff. I wish that we could. But the way that this gets done is it's kind of an interesting surgery. When patients come in, it's a little bit of a long day, but the first step is we actually have to place what's called a frame around the patient's head. Okay. So when you come into the hospital to have DBS done, we place a metal box on your head with a couple pins in the front and a couple pins in the back. Then we have to end up getting a CT scan, and after we get that CT scan, we go to the operating room. The interesting thing about it, and one of the reasons that I love DBS surgery, is it's actually done awake. The whole thing is that we want to actually do testing during the surgery. And so what you can see is someone who's had the surgery done, we can turn the stimulation on and we can turn the stimulation off. And the stimulation and the electricity washes in and out of the brain very quickly. And so you can actually see symptoms come back very fast. And we can see that in the operating room. We can actually do testing on it, which is why we do it with the patient actually awake. We also do it with the patient off of their medications. We want your symptoms to be really bad. So you come in the morning, we put this frame on, we get a CT scan, and then we go back to the operating room. Make a small incision on the top of the head, and then we drill 2 small holes in the brain, or not in the brain, but in the skull, about 1 centimeter across. Through those things, we can actually use that frame to very accurately place these electrodes. So these electrodes go down about 6 centimeters into the head. And then fix everything in place. We can actually run test current while the patient's awake and while we're in the operating room. So we can actually verify that we're in the right spot. And so there's another series of things that we do. We do recordings of the brain while we're doing this. Different parts of the brain sound different. And so we can even hear if we're in the right spot. And so during the surgery, we have all this different feedback to make sure that these electrodes are getting into the right area. Once we do that, we actually run them underneath the skin down to the battery, and the battery ends up getting put in the chest. Okay. Surgery usually takes us about 3 to 4 hours to do. It's the kind of thing that we do when you're in the hospital, usually for 1 or 2 days. We do a lot of these. I would say historically, probably 250. How many people have implants right now in the United States actively?
In the United States.
250,000, 500,000?
Yeah, about 200,000.
About 200,000? Okay. One thing that we do talk about is that when a patient comes in and they're interested in this for Parkinson's disease, this is the kind of thing that you want done. There's more than one area that we put the electrode in. So there's a whole bunch of diseases that we treat with deep brain stimulation. And depending on what disease we're treating, we actually target a different area in the brain. So there's some patients who have Parkinson's disease that one target in the brain might be better than a different area of the brain. And so depending on exactly what symptoms you have, or what kinds of side effects from medications you get, or what your neurologist wants us to treat, there are different areas that we target, okay? And so by running electricity into different areas of the brain, we can get different effects. And so one thing that we end up having to talk to patients about a lot is, what's the goal of the stimulation? Is the goal of the stimulation that for us to treat your side effects from your medications? That's going to lead us to one target. If the goal is for us to treat something like your rigidity, that's going to be a different target than if we want to actually end up treating your tremor more. So there's a lot of different thought process that goes into this, and anyone who's had DBS surgery is going to tell you that there's a lot of workup that we have to go through. You have to do things like we have to test you with your medications on, your medications off, to find out how much improvement you're going to end up getting from the levodopa and carbidopa, because that tells us how much improvement you're going to get from DBS. We have to do a series of special MRIs, and we have to do a series of psychological testing, because Parkinson's disease is not just a motor disease. It actually affects a lot of different aspects of your life. And we have to find out how much of the other aspects of your life are getting affected, because that will also help us guide where part of the brain we want to end up stimulating. The good news about it is that if we do the surgery and it's successful, a good rule of thumb is that it's going to take you about 10 years back in terms of your disease progress. And so wherever you looked like 10 years ago, that's what you're going to look like after we do DBS surgery if it's successful. It's a relatively safe surgery. There's really only about 1 or 2% chance that there's going to be a major complication from it. So as long as we're successful, a majority of patients are going to get a great deal of benefit out of it. Okay. There are some targets that we can do. Specifically, this one target's called the subthalamic nucleus, or SPN. That's one of like the mainstays for Parkinson's treatment. That if we target it and we get it correctly, you can actually also come down significantly on your medication. And so that's another benefit that people have. So when we talk to patients, we talk to them about, are you having lots of side effects from your meds? And if the answer to that is yes, then we end up targeting the STN, because you can come down a lot on your medications and your side effects can get better. There are some patients who are having issues with gait and walking. That will end up leading us to another target called the GPI, or the globus pallidus internus. So part of the workup is making sure that you're still getting a lot of benefit from your medications. Part of the workup is making sure that we're targeting the right area. And that's kind of, again, a discussion that I end up having with your movement disorder neurologist. But once we make the decision to go ahead, doing the surgery is something that we do pretty routinely. Again, it's the kind of thing that is relatively safe. Other things to know about it is, after the surgery, we don't end up turning the battery on right away. Typically, what we do is we do the stage 1, which is the wires into the head at one operation, and then we come back 2 weeks later and we put the battery into the chest. We do that for a couple of reasons. The main reason is that the battery in the chest is a surgery that we actually do with the patient asleep. Okay, and so generally we We like to get the patient out of the operating room because you're off your medications for the wires to go into the head. As all of you guys know, Parkinson's patients, when they've been off their meds for a while, that's not a very fun day. So we like to get people back on their medications. So we like to get them out of the operating room. So that's why we bring them back for a second procedure 2 weeks later. We don't actually start the programming for about 6 weeks after we put the wires into the head. And the reason for that is that there's a lot of healing and things that have to happen with the brain. And as that healing occurs, there can be lots of inflammation around the wires and everything. And so it can be very difficult to actually turn the electricity on and accurately program it. So we wait for all the healing process to happen. That takes about 6 weeks. And then you end up going through a series of programming with your movement disorder neurologist. They'll turn the system on. And then it usually takes 5 to 6 programming sessions to kind of reach your ideal settings, okay? They have to change the amount of stimulation, change the way that the stimulation is getting delivered. So they do that over a period of different visits with them in the office. Again, usually that takes several visits. Some things get better right away, but some things take a little while to get better. So once they've reached your optimal stimulation parameters, then you don't have to go back, except for your regular visits. At that point in time, you'll see me one more time. Usually I like to see people after their programming is done. And then basically the system's just running on its own. It continuously stimulates right now. That's the way that most of the batteries work for right now. They just continuously stimulate. And the batteries usually last 3 to 5 years. Once the battery runs out, it's actually a really easy procedure to go in and take the old battery out and put a new battery in. That usually is about a 30-minute procedure. It's a lot faster than the other 2 procedures. Okay. The other good news about DBS is there's new stuff that's coming out all the time. In fact, pretty much all the companies over the last, I would say, 2 years or so have actually come out with lots of new technology. Until about 5 years ago, a lot of the technology we were using was really like late 90s, early 2000s. All the leads and all the wires and everything have actually just gotten updated. So it's kind of like when you're waiting to get like a new computer or a new phone. You want to wait until after the new ones come out so that you know that it's going to be the most updated one for a while. The good news is that people who are looking into getting it right now are getting like the newest technology. Okay. Having said that, the companies have to make all their technology like backwards compatible and stuff. So once you get the wires in the head, we tend to never screw with those ever again. As long as the wires are in the right spot in the brain, we like to leave those in place. The battery technology is the stuff that's really getting updated these days. And so this is another reason I generally don't recommend getting the rechargeable battery, because every 3 to 5 years, the battery is totally brand new. And so the battery lasts longer, or it can do new tricks and new gizmos. And so that's one of the reasons that we like to replace it. So we do this, and I do this a lot for Parkinson's disease. I've done a couple hundred of these procedures throughout my career. And it's one of the most satisfying things to me personally, because you get to see the effect in the operating room. A lot of things that we do in neurosurgery takes a while for the effect to take place, but for Parkinson's disease surgery, you get to see it like right there in the OR. You get to see the tremor improve, you get to see the rigidity improve, you get to see all that stuff in real time during the procedure, which is incredible. Having said that, there's lots of other diseases that we treat with this. We treat essential tremor with it. We treat epilepsy with DBS. You can treat obsessive compulsive disorder with deep brain stimulation. You can treat addiction. I've treated pain with it. You can even treat depression with it. So it's kind of a treatment and surgery that we're now using to treat all kinds of things. And so we started off with treating tremor and treating Parkinson's disease, but over time it's kind of grown into this thing that we can actually use to treat all kinds of diseases. That's something that we're looking at doing at UPenn. So something I'm very passionate about. It's why I got hired to come here. I spent a long time doing it, and I think that it's something that gives you a ton of benefit for patients. There's a lot of research out there now where people have looked at how much benefit do patients get from it, and per dollar spent, it's one of the best things that we can do for patients in terms of quality of life. So people get a lot of benefit out of it. It can improve a lot of different things, and so patients tend to be very happy. They get a good result with it, which happens the majority of the time, and so that makes my life as a doctor a lot easier. Well, yeah. So are there any questions so far? We'll start with you. Yes, so you can get some benefit for dystonia. So dystonia is like a whole kaleidoscope of different diseases. We do treat dystonia with it. I've treated cervical dystonia with it a lot. Is a common one to treat. You can get generalized dystonia you can treat with it. The target for that is similar to the target for Parkinson's disease. So you can target the globus pallidus internus. Some Parkinson's patients have a lot of dystonia as well. That can be a symptom that they can also have. And we would just target GPI with that. So yeah.
In terms of what the main problem is.
Yeah.
So you have on-off symptoms,
Yes.
and you also have motor dysfunction, you have motor. What,
So the benefit for DBS, if you look at like on the exam question is always, what's the benefit of DBS? And the answer is you get more on time and your motor fluctuations will get better. So that's like the standard answer that people give you. Both targets for Parkinson's disease will give you excellent results, and they're about equal. Having said that, there are some symptoms that would lead me towards picking one of them over the other. If you have dystonia, and I would pick GPI, because GPI is going to give you more ability to control that than subthalamic nucleus is. If you had the need to come down more on your meds, like you were having terrible side effects from your medications, that would make us want to target your subthalamic nucleus. It's not a cut and dry answer, and there's no one size fits all for Parkinson's patients. Every Parkinson's patient has slightly different symptoms for a whole variety of reasons. This is not like a decision that I just like make willy-nilly. Every patient that we're going to do DBS on, we end up discussing at a conference. So now we have a conference every month. We go through an entire list of patients who are coming up for surgery, and all the movement disorder neurologists and myself sit down. We sit down, Karen's in the room. We sit down with our neuropsychologists, with our social workers, and we all talk about, well, what do we think we should put it? Where do we think we should put it for this patient? What should our target be for this patient? Huh? So yeah, so that's another good question. So I would actually, generally, I wouldn't take it out if let's say we did one target in a patient and we got some benefit, but not as much as we wanted. That prompts a whole series of other kinds of evaluations. Did the patient really have Parkinson's disease, or do they have a functional movement disorder? So that would be like the number one question. Did I get it in the right spot or not? That's the question that I have to like ask. We do it on both sides at the same time. So we do it on the same spot. Yeah, we do it on the same spot, both sides. So we can go in and move it. We can. I never leave the OR without it in the spot that I want it to be at. So we actually do a CT scan before we're done with the procedure. And that CT scan will tell me if I ended up targeting correctly or not. No, wait. The CT scan adds about 15 minutes. We do a lot of things. This is a kind of system that you're going to have in your head for sometimes 20 years. I did a battery change on a patient when I was in my fellowship in Toronto. It was that woman's 5th battery, and she'd had the system in for like 24 years. So it's the kind of thing where we have to be perfect. Yeah. So they can have it in for a while. So we do a lot of things to verify it's in the right spot. We do recordings in the OR to make sure we're in the right spot. We do clinical testing in the OR to make sure you're going to get benefit, and we do the CT scan. So we do a lot of things to make sure we're going to get it in the right spot. We can go back if we're convinced that patient had Parkinson's, but we thought, well, maybe the other target would be better. You can just go back in and put 2 more leads in, put a whole second system in on top of the first system. That's something you could do, and I've done that once or twice. Yeah.
If you're just recently diagnosed with no physical, noticeable,
Yeah.
when do you wait to do this, or would you still do this operation?
This is a good question. Okay, so they just finished a trial called the Early Stim trial, where the question was, look, we know a lot of people are going to get benefit out of it, so why not just do it earlier rather than later, right? You're never going to be in better health than you are right now. Why not just do the surgery now? The trial didn't completely say you should just do it right away. And that could just be because we weren't asking the right questions, we didn't pose it the right way. Most people are going to wait until they've had the disease for about 5 to 10 years after diagnosis. Having said that, by the time you get diagnosed, you've really had Parkinson's disease for several years, right? But you get diagnosed here, right? And maybe we do the surgery 5 to 10 years out, but you really had some kind of symptoms that just weren't completely convincing for the diagnosis for 5 to 10 years before that. I think that I would favor putting it in earlier rather than later, because why not? It's a safe procedure.
Quality of life.
What was that?
Quality of life.
Quality of life, you know, you're gonna get the benefit out of it.
I think I might be able to address that from the patient, from the patient side. Because I had it done 5 years after I was diagnosed. And one of the questions that I asked the doctor at the time was, should I wait? Because maybe something new will come up and be the new improved version. He said, really, only you can answer that, because are you satisfied with your current existence? And my tremor was pretty severe, my gait was pretty severe. And I looked myself in the mirror and I said, let's go. I think it's a difficult question to ask, but I think that the point of the question is that at years ago, when they would discuss what's the proper time to do the DBS, the opinion was it's a last resort. And I think that's been pulled back significantly to now approach it earlier.
So what amount of your function did you get back?
Currently I have absolutely no tremor. The only medication I'm on is a new pro patch. My gait is
So you're not. Sorry, pardon, medication.
well, new pro is a cholinergic
It's a dopamine agonist.
dopamine agonist.
But it's not cinnamon, you know.
No. Not on levodopa or I went through the whole routine of trying different medications, nothing was working successfully for me. When I went through the dopamine challenge, which is done before you have this, I had an adverse reaction with the dopamine actually caused the tremor to significantly worsen.
Oh,
Yeah,
So the
I did, but it didn't work.
You weren't getting sick, like nauseous and things like that.
No, but by taking them, I did go through the constipation, I went through all of the problems that you're alluding to.
What about
sleeping?
Yes, who never was on meds? Just skip the whole medication thing?
that's not the most common scenario to be in. That's not super common. And so he alluded to something that's really important, which is there's this idea of what's called the dopamine challenge test, which is something we have to do as part of workup. So when you ask a question like, what percentage are you going to get of an improvement? The dopamine challenge test is you stop your medications at 10 p.m. and then you come in the next morning to the movement disorder neurologist's office and they bomb you with cinnamon, like a lot, like a ton. And then what they do was right before they do that, they do the UPDRS, the Unified Parkinson's Disease Rating Survey. Okay, and that gives you a number. That's how bad your Parkinson's is. You take a ton of cinnamon. They wait an hour until you're in peak on state, and then they rescore you. Okay, and so then what we do is we look at what percentage improvement did you get. So let's say you got 50% improvement, which would be a great dopamine challenge test. That's about the amount of improvement that we'll get from DBS. That's what we advertise it at. Okay. However much improvement you got from that, that's about what our target is. The reason for that is you still need to be dopamine responsive in order for DBS to really work. I will tell you this much. So I have a PhD in neuroscience. One of my passions is trying to figure out how the heck DBS works. We have no clue how it works. It just works. It just works.
I think I was the exception to the rule because the dopamine challenge worked adversely on me.
Yeah.
It just adversely, not.
But I had a 180-degree opposite response.
Right, so then why-
It caused my tremor to exacerbate. It was terrible.
I don't have a good explanation for that, but there's sometimes we can just try things. I know it's like a heck of a thing to say we're gonna try DBS and we're gonna see if it's gonna work. But if the movement disorder neurology team, if the neurologists are convinced enough that this is a good diagnosis of PD, and if you're responsive to the Nupro patch, which the Nupro patch sounds like it works, it might just be that oral Sinemet sometimes hits people wrong. Sometimes like everyone can have a bad reaction to different medications. So if you're still responsive to the Nupro patch, then we know that you still probably have you're probably still gonna be responsive to DBS. Then you just have to sit down with your DBS surgeon and your neurologist, and everyone just has to say, look, this might work, it might not work. If it does, we're gonna look really, really smart. And if it doesn't, well, that's, you know.
My team had seen several cases before of not having proper effects from the medication. And they felt confident that they would be successful, because that was one of the big questions before the decision.
So is there any case that contraindicated that you guys did not?
Yeah, so there are definitely things that make us less likely to want to do it. I mentioned like a functional movement disorder, which is not Parkinson's disease. There are things that can look very Parkinson's-like that are not Parkinson's. They're called Parkinson's plus, like progressive supranuclear palsy or, you know, multi-system atrophy, which are all movement disorder diseases that have Parkinson's features, but are not Parkinson's disease. And they're indicative of a much worse degenerative process in your brain. So that's one of those things that every once in a while we have to like tease that out and figure out what is the actual diagnosis here, and does this person actually have Parkinson's or do they have something else? There are other things that make us less likely to want to do it. You know, there are some people who are just they are not good surgical candidates writ large, and so to do a brain operation on them is not a great idea. And we have some other alternatives for that, but there are things that make us not want to do that. And then there's some anatomical things from a surgeon's perspective that also make it less likely for me to want to do it. Yeah, so that's another reason. So we have to have, okay, so the other part of the workup is we have to have a neuropsychiatric evaluation, because Parkinson's disease can have effects on mood. We also have to have a cognitive evaluation to make sure that you don't have Alzheimer's disease on top of your disease and things like that. So we do have to do some of that stuff as part of a workup, and that can be a contraindication.
So, they work great for you. So maybe a little bit of question for you and for you, and I was a little bit late, so if you address it. Quiet. Is, so what are the downsides? So we see the upsides, no tremor, less freezing of gait, your gait's better. What are the downsides?
I had I don't know if it was an exception, but I had a perfect result, if you want to call it that way. My post-operative events were non-existent. I walked out of the hospital the day after the implanting of the probe. Had absolutely no post-operative pain. I walked out on my way home from the hospital. I stopped off at the restaurant and had something to eat.
I've heard the 2-week like Parkinson's holiday.
Yes.
Talk about.
So my experience with the holiday was after the implant was placed, but the battery wasn't even in yet. I felt as though I was having reduction of symptoms. It was explained to me, and you would be the authority, that the inflammation causes slight swelling of the region where the probe was placed, and it may have caused some of the reduction in symptoms. And then as the 2 weeks pass, when you're getting the battery pack placed, then the amount of inflammation it subsides. Come back.
And
Is that
That's exactly right.
BBS can affect your speech
I had that happen.
permanently?
No. It was more or less when they connected the battery and turned it on, my speech started to be affected. I can't remember honestly exactly what the effect was, but I was walking out of the hospital, heading to the car, and my wife and I were talking, and then she said, you know, your speech is off.
Sometimes it's softer.
I'm not sure what, I honestly don't remember exactly what it was, but we went back, we turned right around, back to the office. And with some minor adjustments of the neuromodulation, it was taken care of.
Yeah.
But since 2019.
In terms of in the OR, if they have all of their off symptoms and their tremor, how are you able to plant this little tiny thing? They fix that on the table, is there a claustrophobic component?
So this is where the frame comes in. The worst part of the surgery was putting the frame on, wasn't it?
Let me correct one thing that he's saying. All of you are sitting here going, you're not awake. You don't have to be awake.
True.
You have to be a level of anesthesia where they can accomplish what they want to accomplish, and you don't have to listen to the sound of the drill going through your head. Okay, so there's a level of sedation that's something in between. That you certainly, because I'm telling you, I'm listening to him, I'm going, you know, and I was a dentist. I spent my life drilling holes in people's heads. It's not true. You don't have to go through that.
So you're on. So you, depending on how the anesthesia team and how the surgeon want to run things, I run a drip of what's called Precedex, which is a very nice sedative. You're going to be really nice and sleepy. In fact, a lot of people do go to sleep while we're doing the opening. So that's running the whole time we're doing the initial part of the surgery. The way that we're able to place things accurately is with this frame on your head. So there's this, what you don't see is that this thing goes on, and then there's this huge, called the shower curtain. There's this drape that goes down, and it sits there behind your head, and then you're just looking down at your feet, and you're in this kind of this nice, very comfy Tempur-Pedic operating table.
And then stop. You're not aware of anything that's going on up to this point.
Yeah.
He has you open, the computers and everything are all humming and going around you, and they've placed the probe, and then he asks the anesthesiologist to lower the level, decrease the level of anesthesia. And you are lying there, and you suddenly have like a veil being lifted up, and you see these bright lights and the shower curtain in front of you, and hands coming this way, and somebody suddenly says to you, tap your hands like, and you see a hand appear, tap your hand like this, and count backwards from 100 by sevens, and they all the tests that they normally run, and you say to yourself, okay, it's the same thing as always. And then he says, now do it. And they flip the switch on the battery pack, and all of a sudden it stops. And he says, now do the tests. It's like you start crying, literally on the operating table, because you can't believe that somebody could turn it off and everything goes back to normal.
And you're off your medications.
Yeah.
So that's the thing. So then the question we love to ask is, when was the last time you looked this good off your medications? And people will say, I don't even remember.
Yeah.
Do you have off time now?
No.
You don't have it at all? Okay,
None.
so we know the 4 cardinal signs of Parkinson, right? We have rigidity.
Bradykinesia, tremor.
So my understanding, so correct me if I'm wrong, is that tremor is, like you said earlier, is DBS is good for tremor. I've heard, like, in terms of sleep, it's like that it helps with rigidity, right? Am I right?
Yeah.
So that, you know, maybe you're not so stiff, so you can like fall back to sleep. But what I heard is it's not, I mean, I don't know if it, did you have any freezing?
I had no freezing.
No.
So this is one of the downsides and one of the risks of DBS surgery, is that it can affect gait. This is a risk of DBS surgery, is gait.
And balance, right? It does not affect that. Are you saying
It can make it worse.
it's
This is another thing that we talk to you about when we're picking our target. because one of the targets is more likely to cause a gait issue than the other target. Subthalamic nucleus, the benefit of it is you can come way down your medications. The drawback to it is that there are issues with, it can cause you to have issues with your gait. It can cause how you have issues with walking. And so people, we don't completely understand why, but it can cause you to have more falls and it can cause you to have more postural instability. So we have to test that. We do some things in the office. We do this thing called a pull test. We talk to you about if you are having falls, if you're not having falls, and that becomes part of the whole, where are we going to target and where are we not going to target?
They may not necessarily then be a candidate.
Or we would go to GPI. So then we go to the other target.
Different target.
We go to the different target.
Sleep now.
What was your target? Were you STM or?
Fine.
Okay.
Has it shown any improvement in with blood pressure problems?
I guess if you were, because your Parkinson's meds can definitely have an effect on your blood pressure. So if you're able to come down to,
I mean, after the surgery, improvement had severe drops in blood pressure.
Right.
I mean, 40 points, if I stand up too fast.
really, that's yeah, that sounds like orthostatic hypertension. That could be from a lot of different things.
Is that
In-
related to the Parkinson's?
It can, it can
Or
be.
secondary to the
It can
medication?
be secondary to the medication.
Yeah.
So if we can come down, if you could come down on your meds, that could potentially improve. Because you wouldn't have to be yeah. Right. So that's a side effect. That could be a side effect of the medications. So then if we can come down on the meds, you can get away from your side effects, which is another reason that we do DBS.
Which has a trickle down effect, because if you reduce the Parkinson's medications, then you need less of the cardiac medications to control blood pressure.
See how that, so it can become this whole thing that like has all these different knock-on effects to different areas.
And orthostatic, and you're lower on medication, but you maybe not be so orthostatic. So you have the drops, right?
Pharmaceutical companies don't like you too much, huh?
I don't care. The device companies love.
So subthalamic is for people who fall?
Subthalamic is for people who do not have issues. Subthalamic is for people who want to come down on their medications. GPI is for people who are having falls or they're having dystonia. That would, yeah,
But you have both.
you have,
Issues with both. My husband has Parkinson's about 6 years.
yeah,
Most of them have. The medications are not working. He's having,
Yeah.
he's a mess. I don't know how to fix it, but,
I mean, the only way to know what the right thing is to have him come in to see him and to find out kind of how bad things are and just decide which one of these. There's pluses and minuses to both of them. And you have to make a decision.
With the gait, I was also explaining that by doing neuromodulation, you can get some benefit over the gait issues from the subthalamic nucleus. It's a question of focusing the direction of the impulse, right?
That's potentially true. And with the new leads, so the new wires that we have, they allow you to like aim and steer the current. And so there's the potential that for one of the targets that can have an issue with gait, if that were a problem, we could steer the current away from whatever was causing that issue. The problem is we don't completely understand how to do that yet. And there are people who are actively working on it. One of my friends at UCSF named Doris Wang, Doris's whole thing is doing DBS and analyzing gait and finding ways to not cause that problem.
So was your tremor interfering with your gait? You said it improved your gait and your tremor.
I had two of the symptoms that I displayed was a severe tremor and interruption of my gait. It wasn't freezing, but I was like a rate. I had like a foot drop or dragging. I'd like to just correct one other really important issue. He said that it takes you back to about a position you were in 10 years ago. I had hair 10 years ago. Didn't help at all.
Be ready.
So the indication seems sort of like a moving target to me, like maybe you should do it early, maybe you should do it later after, you tried all medications. But the other thing is, can you talk more about the risk? Because I mean, this is by definition invasive, something it is
Oh, yeah.
infection. Can you cause a stroke doing this? What are the bad outcomes you have to talk to patients
Okay,
about?
so let's talk, okay, so the indications. Okay, let's just talk about the indications just for Parkinson's disease. As long as someone has PD, one of the main indications you're having medication fluctuations or on-off fluctuations, or you're having bad dyskinesias from the medications, you're having bad side effects, and the medications are causing like tons of motor fluctuations. Motor fluctuations and side effects, primary indications for wanting to do DBS. In order to qualify for it, we still want to, majority of the time, some patients are an exception to this, we want to say that you're still responsive to dopamine, which is why we do the dopamine challenge test. There are some other, you have to be a good candidate for a surgery, period. Okay. I just did it on someone who's on blood thinners. So that's not something that, that is something we can get around. That's totally something we can deal with. And then there's some other, like I was saying, some anatomical considerations that we have to think about surgically that we would only find out once we did an MRI. After you make those decisions in terms of when should you do it in your disease course, that is a personal decision. Most of the time, you're not going to have progressed enough in terms of what most neurologists will want to recommend until you've had it for maybe 5 to 10 years. You can have this discussion with your neurologist whenever you want to have the discussion with your neurologist. If you have Parkinson's disease right now and you're kind of interested in it, you can go in and you can talk to your neurologist, say, hey, I just listened to a lecture about DBS. Do you think I'm ready for it or not? You can say, look, the medications are starting to annoy me. I'm starting to have fluctuations, yada, yada, yada. Is this something we can start to consider? And that just becomes a discussion that you can have with them. Again, I don't have a problem doing it. I'd rather do it earlier than later. I'd rather just do it, have the system in, know the system's in a good spot, because it will help you be healthier. It will help you do things like get up and get around and move around. That will lead you to being healthier, and that will lead you to having a longer, fuller life. Rather do that earlier than do it later, right? That's definitely a reason to do it. Now, it's really easy for me to sign someone up for surgery because I'm the person doing it. I'm not the person having it done. I will tell you that it is an overwhelmingly safe surgery. Every surgery has a risk of bleeding. Every surgery has a risk of infection. Infection is definitely something we have to consider with this because it's an implant. Okay, we're putting in non-flesh thing into your body. It does not repel infection in the same way. We do a lot of stuff to make sure that the surgery is done as safely and as sterilely as possible. In several hundred of these, I have never personally had the wires going into the head get infected. Okay, I have never personally had one of the batteries get infected. Now that I've said this out loud, I'm totally screwed, and we're gonna have this phone call. Okay, but there's a lot of stuff that we do to avoid that. Okay, I would generally quote there's a 1% chance of having an infection. It's definitely something that can occur. Again, there's a lot of things that we do to avoid that. There are other things that can happen. When you're putting this is a semi-blind procedure. You don't actually see the target. You just see the surface of the brain, and this little piece of spaghetti goes through the brain and goes down to where it wants to be at. Now, there are a trillion things that we do in the operating room to make sure that it gets exactly where we want it to go. It doesn't get off target, that it doesn't hit any blood vessels. There's a lot of special MRIs and things that we do. Having said that, that can still happen. Okay. Is it common? No. It can result in a stroke. It can result in a small bleed. I would say that that happens 1 to 2 times out of 100 or less. And it really depends. That's wildly dependent on how the surgeon does things and how the surgeon likes to set stuff up. How fastidious they are, how obsessive they are about it, all those kinds of things play into it. All I can tell you is that in my case series of the cases in my hands, the ones that I've done, I have had 1 bleed around an electrode that was deep. And that's, again, probably out of about 250 patients, so out of 500 electrodes.
Deep meaning what?
Small bleed around the tip of the electrode. Okay. And it would not have been possible it would not have been really spottable, except the nurse in the recovery room was incredibly adroit. And she called me and was like, this patient has a small amount of weakness in their hand. They did. We got a scan. They had about a 2 cc hemorrhage around the electrode deep. The next morning, the patient looked totally fine. At 6 weeks, they didn't have any complications from it. Now, I trained, Toronto is where I did my fellowship at. It's the highest volume DBS center probably on the planet. The other guys that I trained with there, one of them did have a couple of bleeds that were symptomatic. And I can think of a lot of reasons that happened. Not to disparage anyone or get into it, I don't do things the way that he does them. So yeah, it's a brain surgery, but it's a relatively safe brain surgery. Compared to like clipping an aneurysm or taking out a brain tumor, it's very safe.
He's really saying that you have to do your due diligence and evaluating your surgeon before you go into that procedure.
Yeah, I mean, that's a good question unto itself. How do you
Yeah.
evaluate your surgeon?
Yeah.
You ask a friend, no.
Yeah, so you want to, yeah, that's a tough question.
She said 3 to 4 hours, I'm hearing 8, I'm hearing from other people.
Again, yeah, so okay, so let's answer this question really fast. How do you evaluate your surgeon? I would ask them, any surgeon, you should be able to pretty bluntly ask them, how often do you do this? What are the kinds of complications you see? How do you think you stack up to the competition? You should be able to ask someone that question, and the surgeon should feel comfortable talking to you about that. And you're just going to have to go with your gut if you trust that person or not.
And one more question you can ask him. I'm sorry to interrupt.
No, go for it.
Is how many cases have you done?
Right.
Having been in the medical field, I know the practice makes perfect.
Yeah.
And doing something over and over and over again is going to give you less of a chance of an accident or something that you don't know happened. So when I did my evaluation, one of the key questions, and I surveyed 5 different neurosurgeons in the New York area. And I've looked for somebody who had done as many as the most. That alone isn't enough. Then I was checking on the hospitalization infection rate, what the individual's infection rate was, what the incidence of adverse reactions to the procedure. But you really do have to, if this is something that you're going to do, you have to look into who you're going to use.
And I assume your neurologist can help you with that too.
They're going to have someone that they usually like to work with. Most neurologists are going to have a surgeon that they work with most of the time.
That I felt was biased.
Yeah.
Personally.
That might be.
Yeah.
That might be. I will say one thing about that though. The person who's done the most is not always the best.
No.
Reps in the OR, and this is what I told all my junior residents in training, reps in the OR make a big difference. Having said that, there are people who've been out for a while. This whole thing I've talked about, where I've talked about using different targets or using better technology or doing the most up-to-date form of the surgery. There have been people who've been out 20 years that do a great surgery, but if they only put the lead in STN and you needed GPI, then you got the wrong surgery. Okay, that can 100% happen, and there are a lot of different ways to get the surgery done. I've trained with a lot of different people. One of the people I trained with is world famous at it, and he only puts the holes to go into the head in the same place every single time, which is fine, and he's been doing it forever, and he's great at it. But a lot of people plan that because they want to plan around getting around blood vessels and making sure that they don't hit certain structures on the way in. Okay, so just because someone's done a lot of it or they've done it for a while doesn't necessarily mean that they're hyper obsessed about all of it. I will also tell you that you want to go to someone who this is what they do. There's a lot of people who go through neurosurgery residency and they think, I did 50 DBS cases, I can do this when I get out. I did 150 in residency, and I 100% could have just done it when I got out, but that wasn't the point. The point was to go and do another year of it, to see a different perspective on it, and then just be like, this is the thing that I do. I have to do other stuff because I have to pay the bills, and DBS doesn't really pay the bills for the most part. But this is what the passion is, and this is what the obsession is, because the difference between a good result and a great result, or a great result and a terrible result, is a millimeter. And there are a lot of people out there who are doing it and they're thinking, I'm doing a great job. And they maybe are getting 70% of the benefit. But the person who this is all that they do is going to be way more obsessive about it. And that's another thing that I would look at. I say, what percentage of your practice is DBS? Is this most of what you do, or is it not?
Just to add one more piece to that. There are 3 companies that make the the implants, and that's Boston Scientific, Medtronic, and Abbott. Each of them have representatives who are in the OR, working with the doctors, who are invaluable sources of information for you. And so part of the decision-making process that you need to do is to figure out if there's a specific reason why one is more advantageous to your needs than the others. Personally, the virtual ability to program and come to my aid if I needed it suddenly from the Abbott unit, whereas the others can't be programmed remotely, was an important part for me. So I then needed to find a surgeon who liked using the Abbott units. And really, I spoke to Joe Pagano. I've been friends now with him since my surgery, to try and assist me in picking out the surgeon that would be answering all the, or close to answering all the questions that I had. And so that helps you.
Mhm.
Can we just take you with us?
Yeah, sure. Fix your teeth.
I mean, that's, by the way, that's another excellent point, because there are 3 companies. Each of the companies has tried to differentiate themselves in many different ways. Writ large, they all give you a good result, but each of them has like their own little thing that they like to differentiate themselves. The Abbott does remote programming. It's called Neurosphere, and for a lot of people, it's really awesome. I think in Connecticut, I think the interesting thing is you could fly down to Sarasota Springs and we could still program you over the phone. Like theoretically, that's possible. You don't have to drive anywhere. They can do a lot of the remote programming, especially once the programming is settled. They can do that. That's a great advantage. There's a company called Boston. Boston has some interesting ways that you can program things on the leads differently. So from a technical perspective, it's got some interesting things that you can do with it. Medtronic has an interesting thing where they can actually record from the brain, and theoretically one day we'll be able to use that to modulate how we're stimulating the brain. It's called Sense and Stim. So another thing that you can use when you're talking to your surgeon is you can say, what devices do you implant? You will find that some people, they only implant with one company, and I will let you think about why that may or may not be the case. So what I can tell you is that when I did residency, we only implanted Medtronic, and a lot of Medtronic hardware. One of the reasons I went to Toronto is because we did Abbott, we did Boston, we did Medtronic. Okay. We're going to have all 3 of those at UConn. And so one of the things that's happening, that's a great point, is that when we're talking about where should we put the leads, the other question that we talk about inside of this conference is we talk about what device should we put in. And so we have the option to put in Abbott. We have the option to put in Medtronic. We will have the option to put in Boston, but not all reps are Joe Pagano or Saul Mani, and the Boston reps certainly aren't that way. So I have to find a good rep to come down and actually bring us the stuff. That's another good point, because you might have a preference, and that's again the kind of thing that you talk to your surgeon about. Like, look, this is what I want. A lot of people come in and they're like, I think that this whole Sense and Stim thing from the brain is really awesome. Okay, well, we're putting in Medtronic because Abbott doesn't have that. Or I really want to have remote programming. Okay, we're putting in Abbott, right? And that's the kind of thing that you can talk to your surgeon about. Some surgeons will be able to do all of them, some won't. And you want to have a lot of experience with the different hardware to be able to do it.
But let's say it's extreme example. Let's say a surgeon has done 600 with the Medtronic, never done one with the Abbott. I'm interested in the Abbott one. Should I not go to that surgeon?
You can still go to them and you can say, I'd really, really like the Abbott done. And they might say, okay, yeah, fine, we'll figure it out. It's not inside of the operating room. They're not wildly different. There's some parts of them that I like better than others. Like the little thing that goes in the hole to hold the electrode in place. Okay, because we don't just leave this hole just sitting there with like the wire. We have to secure the wire to it. Abbott makes the best burr hole securing device of all the companies by far. I think you'd agree with that. Having said that, I like the actual leads that Medtronic makes. I actually like those better than the other companies because they just feel more solid to me in my hands. Those are all just random little preferences I have. But once you've done, I would say 10 or 15 with a company, then you feel pretty good with how this stuff works. Plus the rep's in the room anyway, so if I'm screwing something up, Joe's gonna be like, no, 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 like this is actually how the whole cover goes on. And he's gonna be sitting there like giving, kind of giving feedback.
And your needs for contact with the company through the rep doesn't stop at the time of the surgery.
Yeah.
For example, I'm going in for an MRI in a few weeks, and they have to turn off the unit because I'll be too much tremor. So Joe actually comes with me to the MRI while they put me to sleep to control the unit. So there are different scenarios where you will have the occasion to be in contact with the rep.
I just want to ask one question from the chat. Can TD and depression be targeted at the same time?
Aha, okay. So depression, DBS for depression has a long and checkered history. There have been a bunch of trials that have failed. I'm currently part of a trial with my old mentor who's now at Long Island Jewish. His name's Al Fenoy. Al and I run a trial for DBS for depression. Our target for this is actually very close to the STN. And so there is the argument, and we are working out how to do this, where you can actually get 2 targets for the price of 1. Joe's shaking his head in the corner because he also knows that Abbott is trying to get my friends at Toronto to sponsor another trial. In all deference to what Abbott's trying to do, they have the wrong target, and there's about,
That has nothing to do with me.
80,000 tons of evidence that they picked the wrong target, but that's my preference. Obviously, I'm attached to one, but theoretically, we might be able to treat some depression with one of the targets for PD. That's an open thing. They're also looking into that in Toronto. We're looking into that a little bit here. Dr. Prakash, she and I've talked about it many times, and she says that every once in a while she does use one of the contacts to do that. So theoretically, that's on the frontier and on the edge of what we can and can't do.
I hear more about those interactions with the patients pre, during, post, how long we follow them up. I've been treating patients with DBS for many years, and I had one patient that was able to control his programming himself with his iPhone. So he walked really well with it on, but then he couldn't work. His fine motor control was off. So then he lowered it, and then he would turn it up and down. So just want to hear about how it can change, and if maybe Randy would show us what it looks like.
Yeah, I used to shut Randy on and off.
No.
Because that is part of my role as a rep, is I do turn people on and off all day long. Good job. I've turned Randy off many times, and then also turned him many times.
It really doesn't hurt. The only thing that happens is the tremor comes right back, and it looks pretty violent when he does it. But it goes away as soon as he turns the switch back on.
Right. I've part of my background is my passion runs through me because I'm a physical therapist by background. And back in the early 2000s, I didn't know what DBS even stood for as a physical therapist. And one of my patients had the surgery done. He came back, walked right past me like he didn't have Parkinson's disease. And I had to stop him, and I said, "Mr. Jones, what did you have done?" And he goes, "Oh, they put something in my head." And I'm like, "What?" I don't know, some wire. Well, I found out about it. I met the representative from the company. He came in and did a new service like Dr. Khan is doing for you guys, talked about the system, and about a year and a half later, I got a job at that company. Because I found the passion of, oh my God, this changed this person's life so dramatically that I want to be involved. So my role with Abbott is that I'm in the operating room with Dr. Connor, and I'm probably one of the only people in the room that I can actually tell him, "Hey, stop doing that, do that."
Yeah.
So, and get away with it. So that's a good feeling. But the whole journey of the process of the patient is I'll meet patients at events like this. I'll meet patients at doctors' offices, and I'll help them, guide them through getting doctor's appointments, through being there with them at those appointments, answering any device related questions that I can answer about my device, about any other device. Medical questions, I do not answer because I am not a doctor. So if you ask me about, hey Joe, can I take my medicine with this one, I'd be like, I can't answer that. I always have to direct those back to the doctor. And you have to deal with the doctor personally with that. So otherwise I'll be like malpractice. I can't, I'm not trained to talk about that. So my whole journey is I'm with families, I'm with patients. During the surgery, I'm actually in there holding your hand, going through the process, making you feel comfortable. My role is that I'm in the operating room and everything is Bluetooth wireless. I'm doing all the programming while you're on the table and let's say you're shaking, for instance. Like kind of like, okay, Joe, it's your time. And I would turn it back on, I would turn it on and see you turn it one away or jittery or whatever that matter is. So I'm there during that procedure, making sure all the products in the room, yes.
So how did you learn enough to be able to advise a surgeon during that in the operating? What training did you get?
From other surgeons. Actually, surgeons trained me. They trained me on every aspect of the case because my passion is not just people, but it's also the surgery. Like I know, even though it's not my product, for instance, like the recording devices, the frame, I know what every little screw goes to because I want to make sure that every case runs smoothly for the surgeon. My job is to be one step ahead of the surgeon. So you come across the room and I know what I hear him talking or I know what tools he's asking for. I know exactly where he is in that surgery. And if he needs like an extra screw or needs something or needs anything, like even from a scrub tech, for instance, I'll let the scrub tech know, oh no, the doctor needs this next. And to make it streamlined because it is an elective surgery. We want everything to go perfect. So I'm privileged that the doctors take me in and take my advice, and they can see that when I walk in the room too, it's like everything is taken care of. They don't have to worry about something. They have to worry enough to make sure that everything goes smoothly, not to worry about anything else. That includes product and the service from everyone in the operating room. So it's, he's the maestro of the orchestra. And I'm just the person who kind of helps guide through and make sure everything goes smoothly. But at any rate, so I do the programming, turn you on, turn you off, making sure that it's in the right spot and when everything's done and closed up. I follow you through the doctor's office for programming sessions. You can call me at any time and say, Joe, how do I move from program 1 to program 2? Or how do I go up and down with the stimulation? Because you'll have full control of your stimulator right through your app on your iPhone.
Joe, can you bring up the Consumer Electronics Show?
I can try.
There was a demonstration of
I
this.
can email it to everybody, by the way. I can email you the link. Yeah.
There's a demonstration of, I was in New York at my home and I was connected via the virtual system to the Dr. Gupta at the Consumer Electronics Show in Las Vegas. And they turned me off at home and had the video camera of me at home. And you see the drastic difference that went on and then turn it back on. So they did use this as a demonstration of the product.
I know I do want to make sure Randy has this time to talk about.
Well, it's okay. What I was going to discuss really was entering the hospital system as a Parkinson's patient and things that you have to be careful of, specifically you with Parkinson's, because their ability to monitor your drug usage is lacking in many cases, and people get into trouble. In fact, if you take all 12 of us sitting here, statistically, 4 of you over the next year are going to wind up with a hospitalization, whether it be planned or emergency. And of those 12 people, of those 4 people, 3 of them are going to have a problem getting the medication on time, getting the exact medication you need. And as a result, 2 out of those 3 people are going to wind up with a complication. Now that's statistically huge. 1 out of 6 are going to have a problem. So my point is the Parkinson's Foundation created something called an Aware and Care Kit that you can go online to the Parkinson's Foundation and it's free, just have them send it to you. But it gives you the opportunity to fill out medical history information and drug information and handouts to give to the people at the hospital. Why don't we pass it around?
Should we pass?
Yes, sure.
You say like bring an extra set of medication.
So that's a hospital by hospital decision
Yeah.
that you'll be faced with. Whether you bring your own medications in the bottles, not in a pill case, but in the bottles to show to the hospital staff what you need ahead of time would be really great if you could contact the hospital so they could order. If you have a certain brand of medication as opposed to the same generic, that would make a big difference to you when you get it and you take it, because the carrier molecule sometimes affects the impact of the medication. So it's really important to make sure they have the medication that you need, that they're aware of your schedule of taking the medications, that they're aware of the actions that those medications or potential interactions those medications could have with other medications. These are all things that the Aware and Care Kit helps.
And Randy, they have to have the medicine bottle with their name on it from the
Right.
pharmacy.
It has to be the current, not a expired one, but the current medication.
But they don't say something like, oh, we don't have that in our formulary, we can't get you that particular med.
If you contact, if your doctor sets this up, if this is a planned stay, you can get your medication by the pharmacy ahead of time to be used during your stay. If it's an emergency, they may not. Then they may allow you to use your medication that some hospitals allow you to use that's coming out of a bottle that's prescribed to you.
Yeah, this is shockingly important to if you do get DBS surgery. When I book a case, I email about 20 people to let like a ton of people know that a DBS patient is going to come through, a couple of whom are the pharmacists. And so we do the thing where if you bring your bottles in, the pharmacist will see you in pre-op, they'll label your bottles, and then by the time you get up to the ICU after the surgery, they're waiting for you. Because once you're done with the surgery, you want to be back on the medication. I even routinely give a Cinemet dose in the OR. Once the moment we're done with like the actual testing and everything, I usually just give a Cinemet dose right there just to get you restarted on your medication. So it's a very, very, very common reason to have issues
Because
after
the
procedure.
psychosis that can develop as a result of missing the schedule of your medication can be life-threatening. And I don't want to stress how important it is.
I have one other question. I was a little alarmed earlier when we were talking about maybe the DBS doesn't work because the patient doesn't actually have Parkinson's. And it seemed to me,
Very uncommon.
okay.
It's possible. Very, 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 very uncommon. But when it doesn't work, that's always one of the things that's like one of the things in the checklist that you have to run down and make sure, okay, is this do we get the right diagnosis or not?
But you got a whole team evaluating.
That's what, yeah, that's why
That's
you
a
know,
reassuring team, real extensive team. You go through neuropsych evaluation, you go through physical exam evaluation, neurologic evaluation. You go through a dietary and a psychiatrist. I mean, it's amazing
it's
how
huge.
involved the workup is. It took, I don't know what your back time is, but it took almost 3 months to make it through the entire process of evaluation.
That's frankly pretty good. Like that's not bad at all.
From that surgery, over 89%, you know.
Right, I mean, it's just with all this sort of evaluation, I'd be surprised that anyone without Parkinson's would get through.
It's not high.
Yeah.
It's not high, but it's on the table.
Yeah.
It's on the table. It's not common. Someone had asked how long the surgery takes. I will tell you that's it's pretty variable from person to person and what their own preferences are. Generally for me, it's about a 4 to 5 hour event. From the time we're starting the day to the time we're done. It's about 4
You
to
place both leads in the same day?
I place both leads the same day.
I only had one done. I only had Parkinson's on my right side.
Okay.
So they placed the lead on the left side.
this is another one of, there's a series of great debates. There's a team in a part of the country that likes to do one side at a time. If you have bilateral symptoms, I would rather just do the whole thing, get the whole thing over with, and just be done with it.
I've been told that even if you don't have bilateral symptoms, a lot of doctors are placing both leads. And I will testify to this. I'm noticing now, 4 or 5 years after the surgery, I'm starting to have symptoms in the opposite side.
Yeah.
And he warned me, he said, I'll probably see you again in 3 or 4 years. Sure enough.
Yeah.
started.
And cosmetically, do you have scars on your head?
You can see the,
That's
It's pretty good results.
And where do the
Good
wires
results.
go to the back?
Yeah, so the wires run behind the ear. We place the leads or we place the battery on the right side typically. And that's just to get away from cardiac effect or like that kind of thing. So they actually go underneath the skin, down the neck, to right underneath the clavicle.
you can really actually see, you can feel the wires.
Yeah.
Okay.
Right here.
There's some
You
things
don't
that
notice it.
there's some things that we can do to recess and to make the bump on the top of the head a little bit less cosmetically noticeable. That we can do to kind of help with that. And sometimes we do.
If you have hair, it helps, right?
Yeah, you've hair helps. It adds about 5 to 10 minutes to the surgery and it's some more drilling. So sometimes we do it, sometimes we don't. I typically do it
For the cosmetic.
for the cosmetic effect. Yeah, I've heard of surgeries that even take longer than this, and that's there's
It's hard.
like it's just it's variable. It depends on kind of how much testing people want to do. You know, there's a lot of variability in how surgeons do things, how they like things to be done. You know, it's an uncomfortable question.
Yeah,
It's not a fun question to answer. All I can tell you is that I've spent a lot of time. Before we did the first case at UConn, we did multiple practice runs. And I got all the hospital staff and everyone involved into the room and we practiced it. We drilled it. And that lets you get faster at things. There are things for people like, you know, there's just some hospitals that are just slower at doing things. Like their hospital staff are just, they don't move as fast. And that's just a reality of the situation.
unexpected events.
Unexpected events happen, you know. Sometimes people want to do things during the surgery that might not affect the outcome, that might make things take longer. There's a lot of answers to that question. There's a lot of answers to that question. I will also say that faster is not always better. Faster is not always better.
The most insurance companies cover the.
A lot of them do, yeah.
I had 100% coverage on Medicare.
Medicare.
I'm talking 100%. I had no out of pocket from anything.
And the
No
diagnosis,
co.
the diagnosis being what?
Parkinson's with motor fluctuations.
Parkinson's one.
With motor fluctuations, that usually gets it covered pretty well. Okay. Yeah, dystonia is a little bit trickier if it's primary dystonia.
The last thing you have to worry about is finances.
You ever have anybody come into this surgery who just said they couldn't sleep and does this help? It's one of the symptoms. I mean,
RBD is definitely something that's a very common complaint people have, and this can help with sleep because we're talking about rigidity and we talked about other motor symptoms and things. It can help with it because of that. Yeah.
It's a life-changing event.
Yeah.
It's a life-changing event. Really.
And if you're not running out, people can come and ask questions. We'll just kind of excuse the people that gotta go. This was really great. I'm already hearing feedback. Joe, who was here, and Megan, everything's been really helpful. I think we needed this. We've been talking around DBS with all of our other presentations, but we needed to hear from the source. So this was excellent. Thank you very, very much.
No problem.
Excellent.
Don't forget to.
I hope I didn't,
I'm actually gonna make you come over here.
I'll be happy to. Where do you think all the way around here? Cause I'm located in one. I came to show.
Yeah, we've got He's got another one set up.
The 11th.
Yes. If it's, you'll probably get a sheet. Sure. I've also got some. Try and set up with the cash, it's like.
Human, recognize that it just doesn't get the audience and. Even though part that doctors.
I had a really good considered residency, so. Feel better.
I know myself, so. I practice my physical as a doctor.
Oh, okay.
That's when the tremor became an issue. But, no, I have to read. Like I noticed we weren't really gonna get my presentation. That's why it's kind of stuck to it, but I did.
I would that a little bit more, like I have slides, and one slide, and I find and pretty much I do it, it's really kind of simple.
Yeah, and the information was that goes to.
Thank you all very much. We will be sending you a survey tomorrow to ask about coming to future events. Take care.
He was
That was
very.
great, thanks.
You're welcome. It was so good, right? I'm so glad we had it. So come to more events, even if it's on Zoom, okay?
Will do.
See you soon, Miles.